To continue our nutrition segment, we're going to start with fiber. Now, fiber, as I mentioned before, it is not a nutrient. It is the part of the fruits and vegetables and whole grains that your body cannot use. So it's indigestible, so not a nutrient. Other names for it are fiber or roughage or bulk. And one of the reasons it's called that as far as bulk is because since it's the part that your body can't digest, it is still a good quantity of content or a good quantity of substance, and so it tends to increase your feeling of fullness. So especially if you're dieting, it's a great thing to try to keep you feel full, so you don't just do mindless eating. It helps lower the blood cholesterol. It's been shown that fiber combined with some of the excess cholesterol in your body, and so before it can get absorbed into the system, it can help things move through the gut and help things clear things out, which can help decrease the risk of some heart disease, and it does help with type 2 diabetes and certain forms of colon cancer as well. One of the things that fiber does is it keeps things moving through your gut so they don't stay stagnant in your gut. It helps increase that peristalsis, those wave-like contractions, to help move things through your system to help maintain your GI health. So when we're looking at food labels, and food labels are really a good thing to take a look at. Sometimes you really don't realize what you're eating until you actually take a look and just monitor that. I already mentioned this, but I really recommend that you write down everything you eat for one day and actually just document, or just total up the calories and the fats and the carbohydrates and the fibers and the proteins. You can kind of really see where sometimes your diet can really be lacking. But nutrition labels tend to tell us how the serving size, what a serving size is, and how that serving fits into the daily diet. Now, most people will take between 2,000 and 2,500 calories a day. I mean, women generally take around 2,000, men more 2,500, but that is going to vary greatly from person to person depending on your activity level. If you're really, really active, you may need 3,000 or 3,500 calories a day if you're super active. So it will really depend on what your activity level is, and then just how your metabolism works, how fast your metabolism tends to work. So some women can only take 1,600 calories a day to maintain their weight. Some can eat 2,000 or 2,200. So it is kind of finding that balance that works well for you. So some of the things that you'll find on the nutrition label, one of the biggest things is the serving size, and that can be so misleading. So this one says it's a half cup as a serving size, and that there's actually 4 servings in this container or whatever this food item happens to be. So if you're eating the entire container, you've got to do the math. Everything's got to get multiplied here by 4, because it's going to tell you the calories per serving, not the calories in the container. It'll tell you the total fat, and if the fat is saturated and if there's cholesterol in it. It lets you know how much sodium is in that item. And then total carbohydrates, it'll tell you if there's a lot of carbohydrates. Now, carbohydrates are a good energy source, but a lot of it will depend on if they're complex carbohydrates, if they're whole grains and they have fiber in them as well, or if there's just pure sugars. If you're just eating a piece of cake, which is just pure sugar, that'll still register as a carbohydrate, but if it's really high in sugars, it's not a healthier choice of a carbohydrate. It also lets you know your protein values, vitamins. It won't necessarily tell you every vitamin that's in the item, but it will tell you the main ones that are there. And then it tells you calories for a 2,000 day diet or a 2,500 calorie a day diet, how much should be from fat, how much from cholesterol. So these are really kind of a nice thing to take a look at. I really thought this was cute. It says, okay, everyone knows their assignment: carrots to the eyes, fish to the brain, milk to the bones, and birthday cake straight to the tush. Absolutely okay to have cake, absolutely okay to have desserts, but again, we just have to remember that those calories don't necessarily produce a lot of nutrients for us, and they are very high caloric type foods, so if you do struggle with weight, it might be something you want to do in moderation. And we don't want to be filling up with things that don't have a lot of nutritional value and then not want to eat the things that are good nutritional value. So we said at the very beginning that there are a lot of things that could impact what you choose to eat and how much you eat. And part of that is age. So infants, for instance, are going to usually start off with breast milk, or, if they're being breastfed, or with a formula. And that formula may depend on whatever the physician tends to prefer or what the family can afford. And then as kids get older, of course, they start eating more solid foods, and usually by, a year and a half, 2 years of age, they're pretty much eating everything. Then diets stay fairly consistent until people get older. Now, once we see people get into, once they age and they become more of a senior status, things start happening in the GI system. And one of the things we see is, one, they produce less saliva, so it can make swallowing a little bit more difficult. They've also, with your elderly population, peristalsis decreases, those wave-like contractions that help move things through your GI tract. And so that can actually lead to constipation and people just feeling uncomfortable. And then sometimes you'll find that certain foods that you never had problems with before, but as you get older, they cause a lot of gas or a lot of stomach distress. And so sometimes people have to, how the food's prepared, or whether it's fried or baked, and certain types of foods may have to start being avoided. Culture and religion can play a big role into this too. So your culture, there might be certain foods that are taboo, or certain foods that you really should eat, especially when you're sick. Some cultures feel like if you have a cold, you should eat hot foods, and if you're hot, you should have cold foods. Finances. Good food is expensive. Lean meats, fruits and vegetables, they're really expensive, so your finances may impact what you're allowed to eat and what you can take in. Allergies. Now, if a person has a food allergy, we have to be very, very careful with this, especially when we're passing those trays, to make sure we have the right tray to the right person. And if they have a food allergy, that we look on that tray to make sure nothing that could potentially be that they're allergic to is on there. Their appetite. So some people just don't have much of an appetite. And then personal choice again, and body reactions. Does the food cause them gas? Sometimes when people get older, as I mentioned, certain foods start affecting them the wrong way. We see that a lot with milk and milk products sometimes. And then if they have a disability. So if they have a disability, they might have to relearn how to feed themselves, and sometimes they need large handled spoons or forks, or they'll have straps on there so they can hold on to it. Some of the residents will have what we call plate guards. It's actually a metal ring that you put around the plate, so their food, when they're trying to scoop up, if they don't have really good control, it doesn't just fall off the plate. There's cups that have handles on them. So there's a lot of different devices that we can use to help a person so they can feed themselves better, or even when we feed them, sometimes we might need special utensils as well. So there are different types of diets, and a diet is the type of foods that you eat. So, I think of a diet as a 4-letter word. It means I have to lose weight, and I have to, start not eating things I want to eat all the time. But your diet is just the type of food plan that you're on. And so we always need to know what type of diet our resident is on. Do they need adaptive equipment for it? And we always have to make sure we have the right patient to the right, the right patient for that right tray, for the right diet. If you have someone who's allergic to peanut and you go in and take them in a peanut butter cookie, you can kill them. Or if they're a diabetic and you're taking them something that's got a piece of cake on them because you've mixed up the trays somehow, it can be really harmful to them. So we have to be very careful with these things. Now, if there is no restrictions on their diet, they can eat anything they want, then they're put on what we call a regular diet or a general diet. So some of the types of diets we might see, one is a low sodium diet. And we did mention that sodium can cause you to retain extra water. If you have a lot of sodium in your body, it might make you feel thirsty, but it does make you retain extra water. And so if you have hypertension, which is high blood pressure, if you have heart conditions, they generally are not going to want that to happen. Because if you're retaining a lot of extra water, your heart has to pump harder to get that fluid everywhere throughout the body. So usually we're going to put the person on a low sodium diet that will help decrease that. And so low sodium diets are usually 1,500 milligrams a day or less. A low sodium serving is about 140 milligrams or less per serving, and no sodium is less than 5 milligrams per serving. Another really common diet, I think I already mentioned this, but in the nursing home, so in a hospital you'll see low sodium 1,500 milligrams a day or low sodium 1,200 milligrams a day diet. In a nursing home it's usually NAS, no added salt, and you just need to make sure there's no salt packets or anything on their food trays. Now, diabetic diets, a diabetic is a person who cannot regulate the sugars that they take in. They either don't make insulin. So normally when you take in your food breaks it down into simple sugars. Your body secretes insulin to help you utilize that energy and that fuel. And so a diabetic either does not make insulin anymore, or they cannot utilize the insulin properly anymore. So they usually are on a diet which will have less carbohydrates. So good protein sources, whole grains, they'll still allow them to have some, a lot more vegetables than fruits, but they need a consistent amount of carbohydrates throughout the day because their medication will be adjusted to that. So normally they recommend half their plate being vegetable, a quarter of the plate being meat, a quarter of the plate being a starch or a grain, and then they can usually have 2 fruit servings a day and then their milk product. So with a diabetic, I cannot stress how critical this is. When you have a patient who's a diabetic, a lot of times their medications are given before they eat. And so now you take them their tray and you don't, they don't feel like eating. You need to find out why. If a patient tells you they don't want to eat, why don't they want to eat? Are they sick to their stomach? Do they just not like the food? Because if they don't like the food, we can ask for an alternative. The facilities will do alternative diet choices for them. And so we can go get them an alternative meal. If they don't feel up to eating, we have to let the nurse know, because if they already gave them their medication, insulin, or their medication to control their sugar levels, and then they're not eating, their sugar levels can bottom out and it can be very, very dangerous for them. So it's critical when you're taking care of diabetic patients that you need to make sure that if they're not eating, if they haven't eaten 50% of their meal, you need to make sure that you let the nurse know. The other thing is with a diabetic is if you take them the wrong tray, do you think they're going to tell you, hey, I'm not supposed to be eating that coffee cake and those cookies? They're not going to tell you that. They're going to eat those first before you catch your mistake. So we have to be careful with it, and we always need to make sure that when we're passing trays, when we take a patient's tray into their room, that we have checked the diet sheet to their name band, and we ask them first and last name, okay, to verify that we have the right person. Low-fat diets are usually done to reduce the risk of cancer and heart disease. So patients that are trying to lose weight, patients that have heart disease issues, they may put them on a low-fat diet. There's a couple other diets we'll talk about with the dysphagia, and there are other diets that your book lists. Your book talks about clear liquid diets, and clear liquid diets are exactly what they sound like. They are clear at room temperature. It's apple juice, it's cranberry juice, it's Jello, clear Jello, popsicle sticks. Those would all count as a clear liquid. Milk, health shakes, smoothies, those do not count. Full liquid diet, though, that would count. So a full liquid diet, milk products, protein drinks, smoothies, ice cream, because that melts at room temperature, those things would all count for a full liquid diet. Now, the term dysphagia means difficulty swallowing. It means the person has an unsafe swallow. And that means that the person could potentially aspirate. And if a person aspirates, they breathe food, fluid, or vomit down into their lungs. And if they accidentally breathe something, so at the back of the throat, down here in the pharynx of the throat, this is where so you have your tracheal opening and you have your epiglottis opening, your esophagus opening, and you have the epiglottis that'll come and close over that opening. So it's important, it really is important when you're doing this, that you want to make sure that that they do have a good swallow, that they are sitting up properly, because if they do accidentally aspirate and food or fluid comes down into their lungs, it's going to come down into these little air sacs, these alveoli, and then that can cause bacteria, it can cause an infection, and they get what we call an aspiration pneumonia, which can be very dangerous and unfortunately very common in the nursing homes. So signs and symptoms that a person has issues with difficulty swallowing: they may have an inability or difficulty speaking. They might feel like their food is sticking in their throat, painful swallowing, just feeling like something's stuck in their throat. And when I say difficulty speaking, I mean more difficulty speaking when they're actually eating. inability or difficulty to swallow, food coming back up. That's called regurgitation, where food comes back up their nose or their throat. They might complain of chest pain or difficulty when they're swallowing, or frequent repetitive swallowing, a gurgly sounding voice after swallowing, reoccurrent episodes of pneumonia, frequent heartburn, unexpected weight loss. Those are all signs of dysphagia, that difficulty swallowing, and things that, especially if this is new, now generally when they have dysphagia, we know it. It's in their chart, it's documented. A lot of times they're on special diets. But if they've never had these issues before and you're starting to notice them, you want to make sure you let the nurse know right away. So one of the things we do is aspiration precautions. When we feed someone or when we have a patient that has dysphagia, we always want to make sure when they're eating that they're sitting all the way up in a high Fowler's position, or they're actually out of bed and in a chair, one of the two. And we want to make sure they stay up for 1 to 2 hours after they eat. We need to make sure that when we're feeding a person, we only feed them with 1/3 of a spoonful at a time. And we do use spoons instead of forks, because if we're coming in with a fork and they lean forward at the time we're pushing the fork back, we can actually shove that fork tines back into the back of their throat. So we want to make sure that we are using a spoon, feeding them slowly, giving them time to eat. If you notice that they're pocketing their food, they're pushing their food over into their cheek, we do want to make sure that we don't keep shoving more food in there. Usually you can just tell them to stop and chew and swallow. Sometimes you can put an empty spoon with no food on it and they'll take it, and then they'll just automatically push some of their food over and start chewing it again. Sometimes you may have to go in with a gloved finger and actually pull the stuff out of the cheeks. So that will depend on them of how they're doing with it. Sometimes if they're having a hard time swallowing, you can have them do a chin tuck where you tilt their chin down and ask them to swallow, and then ask them to swallow again, and sometimes the food will go down a little bit easier. The other thing we do for patients that have difficulty swallowing is they may be on thickened liquids. What thickened liquids does is it slows the food from hitting the back of their throat to give that epiglottis time to actually close over. So it's just a food thickener. It's kind of usually a cornstarch base, and you can add it to water and juices. It doesn't work really well with sodas or things that are really highly carbonated, but generally coffee, teas, waters, sodas, they will, or not sodas, water, juices, they will work fairly well for that. And so a medium thick liquid or nectar thick, and if you've ever had like a Kern's nectar drink, you kind of know it just has a little bit of texture to it. A medium thick liquid, you add enough thickener to it where there's no lumps, but it's just kind of creamy or saucy. Okay. Extra thick, also known as honey thick, you put enough thickener in it that you can actually run it off of a spoon, but it runs off kind of slow, kind of like honey does. You can put a spoon in it, but it'll fall over, but kind of slowly. And then yogurt or pudding-like is just what it sounds like. You're going to add enough thickener until that spoon can just stand up stiff in it. Now, if you could imagine drinking coffee with a spoon, literally being fed your cup of coffee like pudding, people are not crazy about this. They don't usually like their liquids thickened like this. And so again, if you bring but if someone has difficulty swallowing and you give them regular liquids and it goes down too quickly and then they aspirate on it, they can end up with a pneumonia and die. So it is critical you know what your residents' diets are supposed to be. And even though when we're in the clinical setting and we tell you, help answer other people's lights, don't just go giving people food or fluids without checking with the actual CNA who takes care of them. So let's say it's not your resident putting their light on, but the resident next door, and you're trying to help out, so you answer the light, which is great, and they ask you for another cup of coffee. Check with the regular CNA. Just say, hey, Mrs. S wants an extra cup of coffee. I'll get it. I just want to make sure it's okay. Okay, before you just do it, because if it needs to be thickened or if they're on fluid restrictions, that could be really, a potential issue. Some of the facilities actually make water and juices already thickened, but they also have the thickener there. And as a CNA, you are allowed to thicken it. And on the back of this can, there will be instructions. There's actually instructions on the back of this can that will say medium thick, add this many, teaspoons of thickener. Honey thick, add this many teaspoons of thickener. Another diet that you might see with and actually let's go to this one first, a mechanical soft diet. So another diet that we see a lot with our dysphagia patients are mechanical soft diets. And that is for a patient who has dysphagia, but they can still chew and they can still swallow. It's just things have to be a little bit easier for them. And so generally all meat is going to be served where it is a ground consistency. It's like ground hamburger meat. That is the consistency. Now, let's say a fillet of fish, that could be served, because fillet of fish you can actually flake with a fork. Your vegetables will be cooked to where they're overly soft. Mashed potatoes and rice are okay. A soft dinner roll will work, but if you're using which they couldn't have like a hard, crusty French bread, nothing like that. So mechanical soft diets are a diet we usually start our dysphagia patients with. And so if you got something hard, a big piece of steak, crunchy vegetables, there's something wrong with the diet tray if they're supposed to be on mechanical soft. If they're still having problems with aspiration or with dysphagia, even on the mechanical soft, then they go to the pureed diet. And the pureed diet, they will be eating whatever, so the diet, they'll eat whatever the other people in the dining room are eating. It is just going to be blenderized to where it's the consistency of baby food. But please don't make the mistake. These are not babies. These are not babies, and don't treat them as babies, okay? And I see some CNAs just take a spoon and just mix all of their food together. I don't know, would you like to eat your food all mixed together like that? Most people don't. So don't do that to them, okay? They might ask you what they're eating. There's usually right outside the dining room, there is a menu card that shows what they're serving that day, and whatever they're serving, that's what they're getting. It's just been blenderized. So when we're serving food, before you bring a tray into a person, you want to make sure that the person's prepared. Do they have their glasses on? Do they have their dentures in? Have they had a chance to wash their hands, or if they need to go to the bathroom before the food trays come? OBRA, that Omnibus Reconciliation Act of 1987, that federal law that it is for nursing homes, it says that food needs to look appetizing and it needs to be served the correct temperature. Hot food should be served hot, cold food should be served cold. You have to make sure you have the right diet and any adaptive equipment that that person needs. When you're bringing them their tray, the things are covered. So when you're bringing the tray into them, everything should be covered up, and then you would uncover it when you're in the room. Now, if they're eating in the room, we usually put the tray just directly onto their bedside table, and then we just open up the cartons, help them cut up their food, help them, make sure they can get into everything, and then if they can feed themselves, that's fine. If they're a severe dysphagia patient, they need to be fed, then you're going to stay in there. You're not going to take that tray until you're ready to, the other trays have been passed and you're ready to sit down and help them eat. So you also want to make sure, of course, the call light is in reach. And then if they're eating in the dining room, they usually take the plates off of these. They actually take everything off of these trays right here, so it's more like they're sitting down at a regular dining room table. Calculating meal percentage, we will be teaching you with your clinical instructor will teach you this, because all of the facilities we go to do it differently. Some use a point system and some use what we call a plate system. So your clinical instructor will teach you what the facility where you're going to be at works, and just know that all facilities do a little bit differently. But one thing to keep in mind is your milk products. Your milk, your Ensure drinks, your protein shakes, health shakes, smoothies, those are going to count as a food item and a fluid item. So when we start calculating fluid, when we start looking at intake and outputs, intake is our liquids that we're taking in. Meal percentage is our food that we're taking in. But milk double counts, okay? And at some places, juice double counts as well. But usually milk has protein, fats, carbohydrates, vitamins, minerals in it. So it's a fairly complete food item. And so it will double count as a liquid and as a food item. So when we're feeding the person, we want to offer them fluids throughout the meal. So if we're feeding them every 2 or 3 bites, think about giving them some fluids. We feed them with a spoon, 1/3 of a spoonful at a time. Face the person, and you shouldn't be standing up over the person feeding them. You should be sitting down in a chair and having a conversation with them. Because if you're standing over there feeding them, it feels like you're towering over them and they feel like you're forcing them to eat. So you want to just sit down next to them so you're eye level with them. Try not to rush them. I know that's hard, especially if you have multiple people that you need to feed, But please keep in mind there's always extra help for the feeding. So even though you may have 7 or 8 patients during the day, and you might have 3 of them that are feeders, and how are you going to feed all 3 of them if each person takes a half hour or 45 minutes to, because they're a slow eater. But they have the restorative aides will come and help feed. The activities people come and help feed. So there's usually multiple people that come and double duty basically with the feeding. If you have someone that has visual impairment, you're going to describe that plate like a clock to them. Like your chicken is at 6 o'clock, your green beans are at 9 o'clock, your roll is at 3 o'clock. And then if they need help cutting it, you're going to help them cut everything up. And then a lot of times they can feed themselves. Okay, if not, we will help them. And if they want to pray, we would always allow that. And when we were talking about cultural and religious differences, if there's any way we can incorporate that into their diets, we always do. Okay. So this is some of the adaptive equipment I was talking about. There are large handled silverware that is that actually has divots or places for them to grab onto a little bit better. And then there are smooth ones. They can actually, some of these large handled silverwares, they can actually position them. So if you have someone who cannot fork something or spoon something and then turn it, they can actually bend the silverware so it just kind of comes straight up to them this way. They have bowls that have extra lips on them. They have guard plates, which is what this is showing you right over here, so they don't push their food off their plate. They have cups with handles on them. So we have adaptive equipment, and usually the dietitian will take a look at them, or the occupational therapist will take a look at them and kind of help determine what they need so they can be as independent as possible and hopefully feed themselves if possible. Now, fluid balance is also equally important. So water is needed to live. We have to have water to live, and we need water to carry our nutrients. Hydration is having enough water in the body tissues. So when we talk about I and O, that is intake and output. Intake of fluids, not intake of meal percentage, intake of fluids. So the drinks that are on that tray. If the person's getting IVs, the nurse would record that under intake. If they're getting tube feedings, that would be intake. If they're getting any tubes that are getting irrigation through it, that would be intake. So we help calculate intake and output. And if our intake is a lot more than our output, so if a person's taking in a lot of extra fluid, much more than they're putting out, they might end up with edema. Edema is swelling of the tissues. And remember, if a person has a lot of excess fluid in their system, it does make it a little harder for the heart to pump blood everywhere. Output, if our output is more than our intake, then we can get dehydrated, and a person might feel thirsty, their mucous membranes might turn dry, their skin may be drying out. Adults generally have to have at least 1,500 milliliters to survive of fluid, but the normal intake is between 2,000 and 2,500. And one of the things we mentioned before is even though normal intake is 2,000 to 2,500 milliliters, output, urine output for the day is generally only around 1,500. So we know that intake is usually going to be a little bit more than output. Now that's not true for everybody. Some people are on diuretics, medications to help them get rid of excess fluid in their body to make it easier on the heart. There are some special fluid orders that we see. There's encouraged fluids, and encouraged fluids means every time we go in that room, we're going to encourage them to take in more fluid. Okay, we're going to encourage them to get more fluids. So every time we go in to check on them, hey, would you like to drink a little bit more for me? Would you like something else to drink? Restricted fluids is when the doctor will determine that the person, maybe they have high blood pressure, they have heart failure, and their heart's not pumping really well, and they don't want them to have a lot of excess fluid. They will order fluid restrictions, and they will order a specific amount. They'll say 1,800 milliliters fluid restriction or 1,600 milliliters fluid restriction. And then the nurse will determine how to divvy it up. Usually day shift gets more because days has breakfast and lunch and usually at least 2 med passes. And then evening has 1 meal and 1 or 2 med passes, so they'll get the next amount. And then usually they'll only save like 100 or 200 milliliters for night shift, just in case they wake up and they get thirsty or they need a painkiller or something. The term NPO, and what it says here, it says also water pitcher should be removed. it's really cruel to leave a water pitcher in the room and say, but don't drink it. So usually when a person's on restricted fluids, there's going to be a note right above their bed or right in the doorway when you come in, and they'll take the water pitcher out of the room. The term NPO means non per aus, or nothing by mouth, and that's usually before surgery or before a procedure. And some patients, a lot of patients that get tube feedings are also going to be NPO. They aren't going to be able to, if their dysphagia is so bad that they can no longer take mechanical soft, puree diet, they're still choking on it, full liquids, they're still aspirating, they're usually going to end up with a tube feeding, and they may become NPO at that point. And then if they're on thickened liquids, that's, of course, we would need to know if it's nectar thick or honey thick or pudding thick, and we can thicken it as needed. So when we're measuring intake and output, intake is all fluids taken by mouth or orally, and they're measured and recorded. And the measurement for fluids, 1 ounce is equivalent to 30 milliliters. Now a cc and a milliliter are the same thing, and in a hospital setting we usually always use the term milliliters, but in a nursing home frequently you're going to hear the term cc being used. So learn the size of serving containers. A measuring container for fluids is called a graduate cylinder, and each person gets their own graduated cylinder. Urine output, we measure urine, we can measure vomit, we can measure suction drainage, we can measure diarrhea. So we have to make sure that after we empty urinals or bedpans, if we measure them for we pour it in the graduated cylinder, we measure it. Then of course we have to make sure we dump it out, that we rinse it out, that we clean it out, so there's not smells there. We always want to make sure we use medical asepsis, and remember that term, medical asepsis means clean technique. And make sure each patient or resident has their own cylinder. Okay? It should be labeled with their name on it. This is what an intake and output record looks like. This is a weekly. This is a weekly intake and output record where they're just recording each day, and so they've got the whole week here on one form. I actually haven't worked with those. Generally you see daily intake and output records, where there will be a time slot for each time of the day. You would write in oral is by mouth, nasogastric or gastrostomy is a tube feeding, intravenous is an IV, and so you would record whatever they took in orally. So if they had for breakfast, let's say they had 240 cc's of coffee and 120 cc's of juice, I'd put 360 under the 8 o'clock time slot. So it's And we'll be doing some practice things with this, but you do want to make sure that you can make that conversion of 1 ounce is 30 milliliters. So if you served them a carton of milk, and that's 240 cc's of fluid, it was 8 ounces, and 8 times 30 is 240, so 240 cc's or 240 milliliters of fluid, and let's say they only drank half of it. So I would take that 240 and divide it by 2, and I'd end up with 120 is what they took in. So we do expect you to be able to do those simple calculation and addition and multiplications of our fluids. A graduated cylinder, there's all different sizes of them. Some places just use urinals for the graduated cylinders. Some places actually use graduated cylinders. They also make, these are called, we call them urine hats. I'm sure there's a more fancy name for it, but that's the only thing I know it by. And there's actually measurements in here of ounces and cc's or milliliters. The urinals also have ounces and cc measurements, but of course we always record in the cc or milliliter version of it. We do not record things in ounces. And we will stop there.